good afternoon, and welcome to the session today. And I'm Randy Schwartz. I'm a public health consultant from Maine, public health systems consultants. And we know rural healthcare is having a lot of issues. We're having hospital closures. We're having maternity closures. Today we'll be hearing about emergency medicine, paramedicine, and community paramedicine, and some innovations in addressing some of the gaps in rural healthcare. So, rural health innovations often thought to be limited to mobile health vans, telemedicine, and there's a lot of challenges. We have provider shortages. We have, challenges that are often thought to be insurmountable. But by leveraging paramedical and non-medical community members, these rural areas have used their greatest resource themselves to support the health of their communities. The relatively new and evolving community paramedicine model is an example of leveraging community members, in this case, paramedics and emergency medical technicians, to operate in expanded roles with additional training to improve access to care. So in this session of the Health Track, we have presenters from 2 states, from Maine and from Indiana. And we'll start with our colleagues from Maine. From the Maine Critical Access Integrated Paramedics, we have Rick Petrie and Jonnathan Busko. So Jonnathan is a board-certified emergency medicine and EMS physician, lots of experience, 30 years, numerous states, Ohio, North Carolina, Pennsylvania. He has a number of fellowships, residency, disaster fellowship, and I won't go through it all, extensive experience. And he has facilitated tele-urgent care services in Jackman, Maine, which is heading up north. What do they call it? Pioneer type of environment near the Canadian border. So pretty isolated, been through there. And he's joined also does the ski patrol and, the other good stuff that EMS folks do. And he's joined by Rick Petrie, who's the Chief Operations Officer for Northeast Mobile Health, located in Scarborough, and the program, Scarborough, Maine, and the program director for the Jackman Critical Access Integrated Paramedic Program. And he's worked in the EMS system for, I shouldn't say it, 42 years, right? But so Scarborough's near Portland, Maine's biggest population center. So I just said Jackman is isolated, so we're going to hear about that. I'll turn it over to you.
Excellent. Well, welcome. Anyone? Microphone. You want the microphone? All right. All right. Take it off then, if you like. Yeah. I'm not going to. I don't stand still. So. All right. So we'll use the microphone. Hopefully it doesn't overwhelm you, but we will get the video here. We have a whole slide deck, which, if you want copies of, just in the end, I'll give you my card. I'm more than welcome to give them to you. We'll be loosely following the slide deck, but mostly I want you to see what we're saying and have a conversation about it and why what we did, what we're doing is so important for rural communities. I have to put this up here or the woman who coordinates our grant will yell at both of us, and she likes to do that. This was funded with, or is funded, we're in our 4th year now with a HRSA grant, $1.2 million, no other contributions, not to pay for the service, but to pay for everything it took to get it in place. And I guess that makes most of what we did public domain, so I guess if you want that too, let me know, and I'll be forced by federal law to give it to you. So any disclosures? When I started in this, and my role was as a consultant, that's my consulting company, and it's gradually transitioned into making my hospital pay me to do it as part of my real job, so that's great. We'll also mention some government agents and vendors, not because we have any particular preference for them, but because they've been great partners in what we're doing. And then these are all the people it took, all the organizations it took to make this happen. So at the pointy end of the stick is Northeast Mobile Health Services, the ones delivering the service. And down in the corner there is Jackman and the Moose River Valley, the ones who brought this all in. But Maine EMS was important to create this expanded practice that the paramedics are using. Eastern Maine Community College graciously was willing to help us create a program that had never existed before and to support doing that. St. Joseph Healthcare, which is the hospital I work for, agreed both to support what we were doing and also to ultimately to provide the physician, the remote site physician telehealth, and Penobscot Community Healthcare, which is the largest federally qualified health center in Maine, which is in Bangor, but somehow ended up with this frontier clinic 100 miles away that they have struggled for a decade to figure out exactly what to do with, because what FQHCs do and what we're talking about here they don't play in the same room. So this is our service area. And Rick, you want to talk just about the Moose River Valley and Jackman?
Sure. So thanks for having me today. This is where I do my financial disclosures, except I'm a paramedic. There are no financial disclosures, right? So, but the Moose River Jackman area is a really isolated area of the state of Maine, surrounded by woods. It's 15 miles from the Canadian border. It's an hour and a half to the closest hospital from Jackman. It's an hour to the next closest ambulance backup for them to get any help. They have 2 ambulances, but they typically staff 1. The other ambulance is a backup. And when they get called, it's not unusual for them to spend 8 or 10 hours on a call, depending on how far into the woods they need to go, how difficult it is to get the patient out and then transport them. So we've actually come up with some interesting ways to try to cut down on the amount of time they're away. Years ago, when it was a fully functioning 24-hour-a-day health center, what they would do is transport their patients into the health center, and then if the patient needed to go south to the hospital, they would put a nurse and a maintenance worker to drive the ambulance so that the EMS crew didn't have to leave the area. So it really is quite isolated, but it's a 4-season area because snowmobiling, ATVs, cross-country skiing, and then summertime fishing and hiking and mountain climbing and all the stuff that just adds to the public safety nightmare, basically, as a rule. So
exactly. We're just through the moose hunting season. So preaching to the choir, you lose schools, you lose healthcare, you lose a community. And that was the risk. So like just about everywhere in Maine and really across the U.S., healthcare in Jackman started when the nuns came in and said, y'all need some healthcare. And they did it for about 50 years. And then a physician came in who worked with them. They bought a house, turned it into a hospital. Eventually, one of the healthcare systems built a hospital and kind of in partnership with them, which lasted for about 8 years before they said, but you know, it really doesn't make much sense to have a hospital here. So they shut it down as a hospital, but turned those beds into a nursing home and kept the clinic, and the physicians and the nurses in the nursing home were willing to continue to offer the 24-hour emergency care that they had when they were an actual hospital. So in about 2010, the hospital the system that was running this realized, you know, we're not actually a critical access hospital. That's not actually a rural health center, and we actually can't afford to do this because we're not getting any special reimbursement. So they went shopping around the state for a couple years to find somebody willing to take it over, which is how PCHC managed to pick up a clinic 100 miles from everything else. And they said, okay, we're going to shut down the after-hours care, and we're just going to do what FQHCs do. And the community revolted and said, this after-hours care is critically important. The doc who was there said, this is critically important, and I'm willing to do it if you're willing to insure me. And the hospital that had stepped back kept the nursing home running and said, we're willing to let you use the nurses from the nursing home. So they continued to have 24-hour-a-day urgent and emergency care, which was great, until 2017 when the hospital then said, geez, you know, this nursing home thing isn't working out either. So we're going to shut that down too, and we're going to take our nurses. Sorry. And that's where this story sort of begins. So we know there's healthcare workforce shortages across the U.S. We actually have something in the U.S. that I call a practitioner gap. When you think about when PAs started practicing, they basically was your high school diploma or a GED and some additional training, and you became a physician's assistant with the possessive of you worked with one physician and you assisted that physician. And gradually that transferred to the physician assistant and the bachelor's degree, and then now the physician associate, or whatever. At this point, the national organizations want PAs to call themselves, despite the fact that I don't think the laws are ever going to change, nor the licenses, but they are now at a master's level. Same with nurse practitioners. And we created a clinician gap between paramedics, those who can have a high school education and a certificate, and those who, and as someone who started in EMS 30 plus years ago, who worked as a paramedic, I can say that being a paramedic was as close to being a physician as any allied health field, because the big difference is my protocols are in my head. I can give myself my own medical control and change what I'm doing, but the reality is the way we deliver care is almost identical. And that makes paramedics, in a lot of ways, the ultimate clinicians if we can overcome the knowledge gaps. So I'm not going to read all this. Again, get my slides. You can read this. We'll just say that paramedicine's pretty unique because it's entirely dependent on physician practice, but it is an independent clinician delivering that care. They can't hang their own shingle, but it really is, in a lot of ways, back to the original physician assistant model, the physician's assistant, that someone in paramedicine is acting as in some way or another, in a way that's enabled by a physician's practice. So we think of EMS as being the model for it, but it also includes other things like the home health and community paramedicine, mobile integrated health. I taught at Maine Maritime Academy for a few years, and the people who are out there, the medical person in charge, out on a 10,000-ton container ship, days from anywhere, who has 70 hours of training and about 200 medications they can administer. It's the craziest practice of medicine ever, but it's a form of paramedicine. And then for me, the one that really got me interested in this is the Alaska Community Health Practitioner model, which is also entirely dependent on physician authorization of practice and protocols, but is some of the most independent practice you will ever see. So, get this all going, and this, I was involved in this wearing my consultant hat, and this was before Rick got involved. We did a process called Informed Community Self-Determination. Have any of you ever heard of ICSD? It was invented by a guy named Kevin McGinnis, who was the Maine EMS director for years, and then decided to go national and do all sorts of other stuff. But he wrote the Rural EMS Agenda for the Future back in the early 2000s and included ICSD. And what it comes down to is no community has a clue what their EMS is, what they're actually getting, what it cost them, what they could have, and how it ended up existing in the first place. And he said it's really important for communities, particularly communities struggling to maintain EMS services, to have a process for assessing what they've got and then making it happen. And so he invented ICSD, where basically we went in, we had community discussions, we did surveys. We said, we're going bigger than just EMS, but here's what you have for healthcare. Here's what's going to happen. They are going to shut down your after-hours care as of 2021. It's not going to exist anymore. It can't be sustained because they were using their MAs and they were burning them out, and the doc who was doing it has been there since 1988, and she's kind of getting a little burnout too. They haven't been able to recruit a new physician for years because, come to Jackman, Maine, it's gorgeous, you can ski, oh no you can't because you're on call all the time because you're doing 24/7 coverage. Not gonna work. So we went through ICSD, and in the winter of 19 to 20, we actually came up with a plan, which we'll talk about, put it out to bid. Northeast Mobile Health Service was the only EMS agency in the state to bid on it. We laid out two other options. The select boards looked at those options and said, this is the one we want, took it to the voters voted to fund it. And so this was entirely a community-driven process. The community, nobody said, we're going to come in and give this to you or we're going to make you do this. It was, here are your choices, you decide. And whatever decision you make, there's no wrong decision, but they're all informed decisions, and that was the key to the process. So 2020, phase 0, the standalone EMS, although there was some integration because they were it's a small community, they helped in the clinic when they needed to. But all the after-hours care was provided by the clinic. So the first thing we did was create a rural health clinical technician. And Rick, you want to talk about what that role was? That was our transition year, as it were.
So we have the paramedics who are working in the clinic, and as a rural healthcare clinical technician, they would work in the clinic under the guidance of the physician or PA that was on duty at the time. And the way Maine law reads is that they can do that under delegated practice, as long as they're in the clinic and the PA or the physician is there with them while they're doing that. And so they were going through their training. And while we're doing this, we're waiting for the approval from Maine EMS to be able to graduate those paramedics into the other role, the CAPE role. So during the day when the clinic was open, they could work in the clinic as rural healthcare technicians, and then they would respond in the community. And this was, even though this seemed like it was dragging, it was a really important piece, because what it allowed the paramedics to do is to establish a really tight connection with two groups of people, right? The first was the people that worked in the clinic, the doctors and the PAs and the MAs who were there, and with the Jackman Volunteer Ambulance Service, who's been the backbone of that community. No matter what crisis has gone on in healthcare over the last 50 or 60 years, the Jackman ambulance crew, a volunteer crew, were just there consistently every day, responding on calls, doing what they could do, and so it was really critically important that we have that relationship, and to realize that the paramedics weren't there to take over, that they were there to supplement, work with them, and the net result of that is we have a really close relationship. So.
And this is a key point. We were going into a community that had EMS but did not have paramedic level EMS. This would actually be a much easier project if the community was already paying paramedics to be there, because we could just put this piece on top. And our medics don't live in Jackman. They come into Jackman, work 48-hour shifts, and then leave. But by doing this, they were able to really integrate themselves.
And that ambulance service averages between 80 and 100 calls a year. That's what they do for a call volume. So, straight volunteer.
Yep. So I'm not going to read all this, but it was basically the rural health clinical technician falls somewhere between a medical assistant and an RN in terms of the things that they can do. So in that phase 1, there were 2 functions. They were either working as paramedics in the field or doing interfacility transport, or they were working as rural health clinical technicians. But we wanted more than that. And so the two inspirations for the next phase, the critical access integrated paramedic, I spent time in Kotzebue, Alaska, and that's part of the Alaska Native Health System. I flew medevacs and went into the villages where the community health practitioners were working. It was back in 1998, actually that was 2003, and had learned about them back in 98 when I was doing my MPH. They didn't do a lot of emergency care, but they did a lot of primary care, and their protocols were absolutely amazing. It was literally open here, say this, do this, now say this. If patient says this, call a doctor immediately. And just a phenomenal way of being able to deliver care in an isolated community supported by a telemedicine backbone. Additionally, in the mid-90s, there was something called the Red River Project, which was heralded as the future of EMS, expanded scope of practice, EMS. These are paramedics who are doing suturing and urgent care and all sorts of other stuff. And the oversight kind of fell apart, and people kind of forgot the program was running. And by 2003, they realized that these medics were basically practicing like docs. And the state shut the whole thing down, said, nope, that was not the intention. So we were inspired by it and learned some lessons too. So we combined a number of different providers together to create the critical access physician extender. So we start with a paramedic who's working as the rural health clinical technician. We had 6 months of training, about 70 hours of didactics, almost 200 hours of clinical time to add procedures. with the intention of, and this is what sold this to the community, of making every one of these visits a physician telemedicine urgent care visit. Originally, we looked at, could this be a quasi-independent practice with protocols? And the community was like, we've had the doc for years. We're not sure. This was about the same time CMS's emergency triage, treat, and transport program came out, which was allowing these on-scene urgent care televisits. And we said, well, why don't we do that? And the community said, that's it. You figured it out. That's what we want. And so every visit is a physician visit facilitated by a critical access integrated paramedic. So that's our workforce. In the middle is Gladys, who is she is on the Jackman Moose River Volunteer Rescue Squad, and she feeds everybody.
She is our den mother. She doesn't necessarily like that title, but she keeps them in line. She watches out for the paramedics. She when she went away on vacation a couple of weeks ago for a week, the paramedics walked in and the freezer was full of casseroles, and because she was going to be gone for a week, and she wanted to make sure the paramedics ate well, which is not our issue. As you could tell, we have a propensity towards bald paramedics. Caleb's covering up nicely with his hat, but he is bald as well. So, but yeah, that relationship with Gladys is essentially the one that we have with Jackman Moose River Ambulance, and is critically important to the success of the program.
You mentioned that the paramedics do 48s. Where do they go after they go? How do they get back to paramedic?
So basically, we've got two paramedics that live. One lives 20 minutes away. The other one lives about an hour away in Skowhegan. But then I live 2.5 hours away. Corey's the same way. And so what you do is our shifts start at 10 in the morning and go till 10 the next morning. And so the paramedics drive up. And they drive up. They're there for 2 days, and then they swap off and replace. So.
All right. So this is all the training. We ultrasounded tofu. We sutured pig's feet, burned holes through plastic acrylic nails. Did all the urgent care skills that we had identified by actually going through PCHC's records of what procedures they'd done in the last 5 years to determine a scope of practice. Maine EMS weighed in on that and cut out a lot of stuff that we thought was a really good idea. We would still argue it's a good idea, but that's okay. We've got a pretty good scope of practice. There's very little we can't do.
Can you go back for 1 second?
Yeah.
The other thing you'll notice about this, first off, Dr. Busko is the master of simulation, right? The things he can do with hot dogs and fake nails from the store are just absolutely amazing. And sticks driven through them that you snap and create a dislocation. But the other thing is in the lower right-hand corner, you see our telehealth system is grown tremendously, and we are very excited about what we're getting to roll out now. But the one in the lower right-hand corner was the early stages where you have an iPhone strapped to your head. And the physician is kind of watching what you're doing, which looks like kind of a cool adaptation until you've got an iPhone strapped to your head, and you're trying to do things like suture or carry on a conversation with a patient, or just simple things, right?
Yeah, and we were trying in the early parts, and we'll talk more about this, but early on we wanted to be very cost minimizing and platform agnostic. So we said we want to see if we can pull this off with the stuff that people carry in their pockets. If we can do telemedicine with that, then maybe we can get some cool toys. But let's start with that and see what we break. We also did not have great cell coverage in the area, shocking in a rural area. FirstNet, which is the public safety broadband, federal public safety broadband, cellular broadband. Fortunately, that Kevin McGinnis, the same guy who invented ICSD, helped the federal government coordinate the program. And so living in Maine, he was able to hook us up with FirstNet being really excited about building up the infrastructure to the point where we now do all our telemedicine, even in the clinic, which is where we do the vast majority of it, over cellular broadband, not over fiber, although they just in the last year brought fiber into the community.
Yes, yeah, they did. FirstNet's been fantastic. Because they also realize that they can use this as a demonstration project. So they've been really good.
All right, so again, won't cover this other than to say our medics got to do some emergency stuff that the clinic had been doing that we thought was important, and then all the urgent care skills, and that ended up being their scope of practice. With that, we let the rural health clinical technicians do more too, because now we had trained them on some additional stuff, and basically whatever the doc says, they get to do. So phase 2 after hours, if it's a 911 call, theoretically we could flip it to a CAPE, Critical Access Integrated Paramedic call. We haven't yet. We've done one like that where it was actually a community paramedicine visit that we turned into an urgent care call. For the most part, because this is what the community's done for the last 50 years, people just come to the clinic where they pick up a bat phone, which rings to the paramedic's cell phone and says, "Hi, I'm standing outside the door, come and take care of me," and we do. So now it's 3 functions. It's the EMS, including community paramedicine. It's rural health clinical technician during regular business hours. We're still doing the delegated practice work with the clinic. And then adding this critical access integrated paramedic for the 24-hour-a-day telehealth urgent care visits. Now, when the clinic's open, we don't do these, but we could. But when the clinic's closed, and one of the first things they did was reduce the number of days they were open once they knew they had coverage. So they're now down to 4 days a week. The paramedics get the rest. So, yeah, I think we've got enough time. So let's watch this. So as Rick pointed out, FirstNet was really excited. They were so excited that they came and they shot a really nice video.
Oh! Jackman, Maine is in a very remote area. We're essentially an island up here. If you look behind me, that
So so FirstNet decided that they wanted to come up and after they'd done all the work and really kind of spotlight what they'd done up there, what we'd been able to do, and including with just within the last couple of weeks, we've just installed upgraded cradle points, both in the ambulances and in the first response vehicle, and we have a portable suitcase cradle point that we can carry into the woods. So.
Jackman, Maine is in a very remote area. We're essentially an island up here. If you look behind me, that represents pretty much so in any direction what we're dealing with.
Jackman is a pretty unique part of Maine and pretty unique piece of America in terms of the healthcare needs in the community that healthcare there serves.
Medical care in this community is a challenge because we are 75 miles away from the nearest emergency room or hospital. So it's important that we can do what we can here in Jackman and be able to treat people the best way we can.
The fact that a patient can go to that health center and meet with that paramedic, and that paramedic can bring up all kinds of medical professionals through telehealth and FirstNet, and be able to communicate with them and assess a patient for whatever they need and direct the patient in the right area, prescribe medications, is just phenomenal. If that wasn't there, anybody coming in, bringing a family member, friend, whatever, injured, ill, they would have no choice but to drive to the nearest hospital, which is 50 miles away, and most often they go south towards the hospital, which is 75 miles away.
The paramedics, they have their phone, and then they also have tablets that are using the FirstNet service to be able to communicate, which is important here just because the internet service, cell service is all very spotty.
The technology piece has been interesting. Being able to interface with that physician is really the underlying foundation of what we're doing up here. EKG machines or monitors, and able to take that information and send it, again, securely to the physician so they can actually see the assessment portion of what we're doing here in the field.
This is new. This is innovative. The people of the town of Jackman are rural and need access to health care. The key to this is that the paramedics work under a delegated practice in telehealth, which is the absolute key. Starting at 5:30 at night during the week is that the paramedics establish a telehealth connection with an emergency room physician at St. Joe's, and they work collaboratively together to care for the patient and get them what they need. By doing that, we're able to care for patients in an emergency situation using our regular EMS protocols, or we're able to care for the patients for relatively minor but things that need to be taken care of right away to prevent a condition getting worse. And that's an essential piece of that.
For communities that lose access to healthcare and schools, those are the two best predictors for the communities to dissolve, to fall apart. Without easy access to healthcare, communities don't hold together. And so as financial and operational and staffing pressures have fallen onto the Jackman Clinic, just as they have pretty much everywhere else in the US, they've had a need to create access for patients that maintains what's been necessary to hold the community together.
This is really exciting for me because it just opens another door.
So we were super excited that they were willing to do that. And I'll tell you, they were also, those accident pictures, they happened to stumble upon an accident on their way into Jackman, and they were really excited because they had exciting pictures to show. But that's essentially the way that the service, functions is through that connection. And in fact, we have a requirement of AV connectivity to be able to use these protocols to do this work. So this, one of the very silly protocols that we have is the removal of foreign bodies that are visible in the external auditory canal without an otoscope. So if it's hanging out their ear, we can take it out. And that's really silly, except that the very first case we had was a woman who was rushing to go to work. She was cleaning out her ear. The tip of the Q-tip fell off. She had two choices. She could come and use our brand new service, or she could drive an hour and a half to sit in the waiting room in an emergency department, if it didn't bounce out on the way down, for somebody to pull a cotton tip out of her ear and then drive back and be about 5 hours late for work. That's what was pulled out of her ear by one of our medics. And to me, it embodies everything this program is about. This is not about massive new emergency care infrastructure. This is about what are the things that are incredibly disruptive and make it impossible to live in a meaningful way in a rural community as far as healthcare access goes. And this is it. So in the first year of operations, we had 66 total critical access integrated paramedic encounters, 284 total EMS encounters. As Rick said, this is a service that prior to us being there, Jackman Moose River did about 80 to 100 calls a year. These were just the ALS responses. So you build it, they will come. People began using the ambulance service more as well. We also did 64 community paramedicine encounters. This is an area where home health, there are two agencies that this is their area of responsibility for home health. You will never see a home health nurse there. You will never see a hospice nurse there. They're not coming up for one patient. 64 patients who got home health services in home through our community paramedicine program. And we've done lots of suturing and wound repair. We've taken out a lot of fish hooks, put on some splints, and given out a lot of medications. So in phase 2.1, we got the state to let us add a bunch of labs so we can actually confirm that someone has a urinary tract infection instead of just guessing. We can make sure they're not pregnant. We could do the eye exams. Now we can actually treat them with the medications. And we can take ticks off because it turns out ticks are everywhere, including up in Jackman. And we expanded the infrastructure. This is what Rick was talking about buying more tools, both in the vehicles and portable. We added some AMD telehealth equipment, so we got a cart similar to this, a little bit bigger, that is in the clinic that we're going to go live with shortly. We just got everyone trained up, and we got one of the portable units that we're able to take into the field. So if you combine that Pelican box with this Pelican box, you can go pretty much anywhere in Jackman and perform a telehealth visit. So that's something we're really excited about. All right. And then you may have picked up on the mention of prescriptions. So the way our protocols are written, we play, I'm not going to say fast and loose, but we play with the pharmacy rules in that the medics can give a first dose of oral antibiotics, and we can give, there are no pharmacies in town, so they can give them what they need to get through to that first one. But people still have to travel then at their own convenience, but have to travel somewhere to get their prescriptions filled. So the State Board of Pharmacy recognizes there's a rural pharmacy crisis in Maine and across the U.S., and so they are working with us. You can have remote, they call them automated pharmacy systems, which mostly are, we think about the Pyxis in nursing homes where there's not a pharmacist there, but they allow retail automated pharmacy systems with the right people acting as the pharmacy technicians on the originating site end. And so we have bought the equipment, and we're waiting for the Board of Pharmacy to formally include EMS in the list, although they're already informally included in the rules, but to formally include us so that we can start dispensing. If we're going to give you your first dose of antibiotics, we're going to give you the full course of antibiotics right now, and you're going to get it from a retail pharmacy, and they'll bill your insurance, and everything else will happen later. But then we eliminate that last bit. It's important, but a little less important in Jackman, but for some of our future state projects, this is a critically important part of what we're looking at. So we're in present state, we've got that phase 2 where we've got the CAPES and the Rural Health Clinical Technician 2.0. Phase 3, we're working on that fully integrated, much broader practitioner that we call a community care practitioner extender. And we're actually working with one of our 4-year colleges to create potentially a bachelor's program that trains people to fill that practitioner gap, to have a 4-year bachelor's practitioner that's based on the principles of EMS and paramedicine and extends a physician work. So this is replicable. We could do this almost anywhere, assuming that the state EMS agencies would let us do it. But putting that part aside, we can replicate this anywhere. Maine EMS requested that we write up the rules, the protocols, the scope of practice, everything that's needed to make this permanent. So I just submitted that to them. We're going to be reviewing it over the next couple months, and this will become something any EMS agency in Maine that makes the right arrangements could do. And again, that could go anywhere. But we could do primary care. We could do just straight telehealth facilitation for primary care visits and phlebotomy and run more point of care labs and other things that would keep people from needing to go. Because right now I'm working with these people right there who have no health care whatsoever on Monhegan Island in Maine, who in the winter have 60 permanent residents and in the summer can have up to 1,200 people a day on the island at any given time. They have volunteer first aid with physicians and PAs and NPs in the summer, and in the winter everything goes away. And the ferry runs 2 days a week if there's not a storm, in which case it doesn't get rescheduled, it gets canceled. So as one of the people at the town hall a couple weeks ago said, so on Monday night after the ferry leaves, if I'm bitten by one of my cats, how do I get antibiotics? And I said, I have no idea how you get antibiotics. You go around and you knock on the other 59 people's homes and say, do you have any antibiotics? I don't care what they are. May I please have them? I got bitten by my cat. That's a problem for us to solve, and a solvable one. So we've thought a little bit about drones, but the weather conditions out there can be really iffy. But yeah, it is on our list of potential ways of delivering medications. And then we have a lot of unlicensed military medical personnel who are trained but don't have a license, or foreign medical graduates who cannot, for any number of reasons, get medical licenses in the U.S. And yet under our delegated practice laws, as long as I am, as a physician, know that what their training is, I can delegate anything usual and customary to them. So instead of using medics, if it was a community that was bringing in immigrant or refugee populations, and you were getting a lot of people with a lot of training who were going to end up serving coffee or driving Ubers, you could say instead, we're going to use this delegated practice model and really extend what we can do here. So just a couple of quick lessons learned. First, you need a lot of partners to get from standalone EMS to fully healthcare system integrated, and you got to keep working with those partners all the time. This one, and this one was, you can't steal paramedics. Right now, I work in an emergency department where we've hired 2 paramedics, and that's great. It's really nice to have them there. But when we then say, why can't we get 911 trucks to do interfacility transports for us? Say, because the medics who would be staffing them are in our fast track putting Band-Aids on boo-boos. That's why we can't do it. So if you're going to do this, you've got to preserve your EMS workforce in some way, which is something we've done. And then this last one goes to informed community self-determination and the concept that all healthcare is local. And it doesn't matter what your opinions are about how you think healthcare should be delivered. It matters what the community cares about. And so you need to build systems, and informed community self-determination let us do this. You need to build systems that are, so we've got value-based care. This is values-based care. What are the community's values? And communities can't, most small communities, most rural communities don't have the wherewithal to be able to do this on their own, so they need outside assistance, but that outside assistance can't be some big healthcare system coming and saying, oh, well, we're going to add you to our list of captured populations so that we can get better drug pricing with the 340B program. It has to be, what do you need? What do you want? We went through 25 iterations of what this was going to look like before we landed on the final one.
So the other thing that's really important with this is that you have to find the right medics. Without the right medics, this program will fail. It'll flame out right off the bat. You have to have somebody who's mentally and physically geared towards this because they have to integrate themselves into the community. Absolutely, they have to be accepted by the community. They have to integrate themselves into the community, and they have to want to do that. Right? You have to find a paramedic who's comfortable going on an ATV accident at 3 o'clock in the morning, 5 miles into the woods, and thinking under tremendous pressure. And then 4 hours later, sitting at somebody's kitchen table, having a cup of tea and checking an incision or a laceration from a week ago, making sure, right? We've done everything from pulling that cotton swab out of the woman's ear to administering TNK to a STEMI patient and heparin drip, and then loading them onto a helicopter and flying them to a cath lab, right? I mean, it really is. And you have to have somebody who can think outside of the box. This is not typical EMS from documentation and care. And you have to be willing to insert yourself in the community, which means these guys get invited to weddings and cookouts, and because the town just accepts them. And that's really critically important. Communication is key. We had to fight our way through the bureaucracy of EMS because this is different than EMS. But I got to tell you that once we started doing this, we had a tremendous amount of help from legislators and townspeople who said to Maine EMS, oh, this is staying. This is sticking around. This is important. So.
What's your med flight network look like?
We have one service in the state of Maine. They have three helicopters now, one in Bangor, one in Portland, and one in Sanford. Our first one was an abysmal failure. It was a for-profit company where the pilot killed 3 people by running out of gas in a helicopter over Casco Bay. But this one learned a lot. It's Lifelight of Maine. They do a tremendous job with safety, but even in a place like Maine with the drones that Dr. Busko spoke about, Lifelight can't fly about 35% of the time because either a place to land or weather or they're on another call. So you have to build a system that has all kinds of different stuff in it. So, yes, ma'am.
Fun.
Yeah, I missed the first part. Is there a what?
Is there a pay raise associated with
Oh, yeah. Oh, yeah, yeah, absolutely. Now, the reality of it is we gave them a pay raise, which was pretty significant to start with, to be perfectly honest, at $35 an hour to start. And then COVID hit and all the paramedics dropped off the face of the earth. And now $35 an hour is what everybody's paying just to lure them in. So now we have to revisit it. The problem is that the only thing we can't get grant money for is payroll. Right? The money that we have, $1.2 million to do equipment and training and all that stuff, but none of it can go to, and so the people of the town of Jackman, Moose River have to fund that. So, but there is a pay raise. There definitely was a pay raise. So, yes, sir.
You mentioned a little bit about your staffing challenges right now with EMS. Have you found people coming back into EMS because of this as another option, or is it still scant like everywhere else? At
first, we had a handful of people who were really interested, and we had to screen out some of those people because they weren't the right people, right? You can be a really good paramedic and not fit in here because it's not the same. But we also, and then we to be perfectly honest, we went out and hand selected their replacements, and because people weren't really sure what this was going to be. They didn't know what this was about. They didn't know what was going to be expected. And now we get calls on a regular basis of, how do I get into that? Let me tell you one thing that Lifelight of Maine and we figured out right off the bat is right now you can't have part-time people. You can't do it. The training, the education, the upkeep is too much. You cannot have part-time people. Lifelight of Maine figured that out as well. Everybody wants to provide opportunity, but they need to be full-time. They need to be committed. They need to be there. So
we need to get to our next speakers, and we'll see what we have at the end.
Yep. And we'll be around, so we can answer more questions.
Great. Wow, that was great. Okay. All right, now our friends from Indiana. Yes. We have Darren Forman, who's been paramedic for 23 years, volunteer, private, hospital, fire department, all of the above, and a whole lot of other things. Safe sleep instructor, baby and me tobacco free. He's Lamaze trained to deliver birth education, and he was the 2018 State of Indiana Paramedic of the Year. And Samantha Swearingen is the program manager for Crawfordsville Fire Department's Mobile Integrated Health Community Paramedicine program. She's has a public health degree and from Purdue, and came back to Montgomery County, Montgomery Health Department, and has been working for 7 years on public health education and departmental accreditation. And they'll talk about their Project Swaddle. Yes, sir. All right.
We do not have slides, so we are just going to talk to you this afternoon. But thank you again for those introductions. And again, I'm Samantha, and I manage the programs that we have at the Crawfordsville Fire Department Community Paramedicine. Or interchangeably, we use Mobile Integrated Health. So you'll hear those back and forth. But just want to give you a brief overview of who we are and where we come from, and kind of just a brief history of how we started, and then I will hand it over to Darren to speak more about his program. So Crawfordsville, Indiana is the seat of Montgomery County. We are in the west central part of the state, about 50 miles away from Indianapolis. Crawfordsville itself is about 16,000 population. We are a very industrial, manufacturing town, so very blue color. We do have, we're kind of unique as far as the roads that go through Indiana. We're very close to, we can get to Chicago, Cincinnati, St. Louis, Detroit. So we do get a lot of pass through. But our county itself is about 38,000 people, so we're quite a bit larger than our colleagues from Maine. So this program started, like I said, we were with the fire department. Our firemen are also paramedic EMTs, with majority of them trained to be paramedics. And about 2013, our mayor at the time, who was also a retired fire chief, started looking at these ideas of community paramedicine programs. Majority of community paramedicine programs throughout the United States are based on those 911 reductions. So our guys were going, our people were going out quite a bit on falls. So you'll see a lot of these programs being built on falls prevention. So going into the homes of the elderly who are consistently falling, and then to also reduce those ER admissions in our hospital. So our community does have a hospital, Franciscan Health, and we started talking with them on how can we reduce our calls, 911, but how can we also reduce those ER admissions? As we got to speaking with those partners at the hospital, they also started at that time their ACO clinics. Have you guys heard of? Okay. So they're affordable care organizations. So they have nurses that are also looking at reducing chronic disease or helping with chronic disease management. So we then had the idea, well, why don't we go together and pilot a project? And most of our readmissions at the time were actually on congestive heart failure. So we started working with those patients. We had a paramedic at the time. Fireman paramedic was getting close to retirement. So again, looking at, has had a long career, has had a lot of experience with a paramedic or as a paramedic, and we pulled him off the truck. So no longer doing those calls and really focusing Monday through Friday, 8 to 4, going to these patients' homes and doing the care at the home and however that needed to be. So very tailored to the patient, but through that physician extension. So we still had medical direction, but again, wide scope of practice. Paramedic is able to do whatever is needed. So with that congestive heart failure, they're able to do vitals in the home, med recs, labs.
iStats.
Yeah. So they're able to do whatever is needed for that patient. But what came on the other side of that was also social determinants of health. So the other half of healthcare. So what does their home look like? We're doing home safety assessments. Do they have transportation to their appointments? What's their food look like? Do they have access to other areas of care? So it was kind of really focused on that medical piece, but we also need to make sure our medics were trained to be able to provide those other warm handoffs or do that education with those other services. So that ended up being really, really successful. We ended up having 0 readmissions into our hospital with our pilot. So Franciscan Health at the time saw a lot of value in that and decided to fund 2 of our medics to work on that program. So with the successes of that, we decided to partner with our health department at the time and look at the community needs assessments. What else can we do in this community that is lacking? Where are the gaps? And this is where the maternal infant health piece comes in. We lost our hospital birthing unit in 2011, so we were starting to see a lot of issues arise from that. We also had some fetal infant loss. And Indiana actually has quite a bit of fetal infant loss. So it was not only on the radar in our community, but at the state level as well. So this is where Mr. Swaddle comes in. We started a program and piloted another one called Project Swaddle, and I will pass that over to Darren to speak about the inception of that.
All right, so given the time constraints, I'm going to talk a bit like an auctioneer myself. So I hope we get everything in. First of all, I want to give a huge tip of the hat to our previous presenters. I've been to Maine. I've been in that area. I might have been coming after one of those critters that run around those woods. So I know exactly what you're talking about as far as just a gorgeous place on earth, but really tough to practice. I can only imagine. So thank you for pioneering that. The things that you're doing with the medics, you go back to the Red River discussion. I was in what I would call the meat of my career when all that discussion was going on. And I was super excited about it when I read about it. And then you're right, it just kind of went into the good night. My background is I've been a paramedic for about 30 years. Primary practice was 911 paramedicine. I was recruited to the fire department 23 years ago, and from that time, I was a firefighter paramedic, which meant in a small community, you do a little bit of everything, which is, I think, the best way to do it. Firefighting is not a get-rich-quick scheme. So we all have a side hustle. My side hustle was I worked in an emergency room because it was 73 and fluorescent every day. Indiana is also a 4-season state. Some days I'd be losing because I could have been really riding my motorcycle and enjoying life. And then some days it was like, you guys go push that snow. You have fun with that. So I'll be here in the ER waiting on you. So when we chose our paramedics, as Sam alluded to, one of the things that you guys spoke about struck me as a common thread is it takes the right person. You can't just come off of a truck and start practicing in this expanded role. Unfortunately, however, I did not get a bump in pay. I do work for the fire department, and we're all even. But what our chief did, Chief Paul Miller, he did come to us senior medics, our seasoned medics, translates to old guys, and said, you guys have been working in the ER. We want to expand these programs out. What do you think? And we're like, oh, yeah, whatever. That sounds great. And I get to go to days. After 20 years or so of waking up all night, every night, you're on duty. It's kind of nice to sleep in your own bed every night. It was an adjustment for my wife. But it worked out. We're still married. Yeah, exactly. So we were going full throttle toward this reduction of readmissions for congestive heart failure. And then our friends at the health department come up with this problem that we have with perinatal care and fetal maternal death and bad outcomes. So I've been a car seat technician for about 20 years, ran the only car seat technician site in Montgomery County, which was another one of those additional duties to the fire department duties that I did not get compensated for. But so Chief Miller come to me and he says, hey, we've got this idea. What do you think? And I thought, well, what am I going to do? So we started out as a social connector. So I would go to the home and I would make sure the mom had prenatal care lined up. That's huge. Make sure we were able to go to SNAP if we needed it, get to WIC if we needed it, and get any other care such as a primary care doctor. A lot of our younger population doesn't have a primary care doctor because they don't need one. They're never sick. If they are sick, where do they go? ER or urgent care. They don't have that primary care guy or gal to watch over them. So I thought, well, that won't be too bad. We started looking at things that I would have to do for additional education. Period of purple crying, which talks about soothing your baby and understanding that it's okay when your baby cries. We have things that we check, and if the baby's still going to cry, the baby's going to cry. Put them in a safe position, walk away if you need to, and then come back. Safe sleep. I had heard the back to sleep. Didn't understand really why it was that way. So we took a class on that, and I'm like, that kind of makes sense. So I was already a car seat safety technician, so that one was an easy one. My funniest story, or if you will, anecdotally, is when I went to breastfeeding class. So I walk into a room about half again this size. There were, conservatively speaking, 60 ladies in there. And in comes this burly fireman-looking guy, dressed just like this. And I get all those looks. Are you in the right place? And as I look at the front of the room, the mannequins were spread out on the table. And I started seeing some of the girls kind of step in front of the mannequins. I'm like, yes, I'm in the right place. By the time I left that 3-day class, I had a stack of business cards. And they're like, wow, it's just really nice that guys actually care about this stuff. So that was my first experience of, what are you doing? So we started the program. Again, I was going to be the social connector, and I did that for about 3 months. And my doctor champion that I work with, Dr. Scott Sennett, caught me in the office one day because I walk into that office, and fortunately, I'm in there often enough. I walk in, and I'm like Norm walking into Cheers. I think most of you can relate to that reference. I used that a couple of weeks ago with one of my other people in the office, and they're like, "What?" We had to YouTube lesson. At any rate, he said, "Hey, Darren, really like what you're doing, but what I really need is I need somebody to watch over our high-risk moms." I'm like, well, all right, let's talk about it. So we talked about what we were going to do, or what his vision was for me to take care of his hyperemesis gravida patients, to what I'm going to do to take care of his hypertensive patients, his preeclamptic patients, his gestational diabetic patients. And I'm like, well, that sounds like more classes. So we got with our dietitians and learned everything I needed to know, I think, about gestational diabetes. The hyperemesis gravida falls in our wheelhouse. It's really just IVs, give them anti-nausea medications. But then I learned, if I educate the mom on what she shouldn't eat, how she should eat, don't have to do that very often. And so we started kind of figuring out this education piece, because what I found out was, and I guess I already knew this, but typically when you go to your OB doctor, you come into the office and a girl rooms you, get your weight, get your vitals, put you in a room. She'll ask you the usual questions. The doctor will zing in the door, ask you a few more questions, and zing back out of the door. And there's not a lot of education time allotted for our visits anymore. So we were having patients that really didn't have the education that we would have had traditionally back in my age group. Back in my age, when we were having kids, everybody had to go to a birthing class. That doesn't happen anymore. So we started looking at these educational points. As we built the program out, it's very dependent upon the patient. Some patients we see more often than others. Typically, we see the patient every 2 weeks until 36 weeks. Then we will see them every week. The return from having the baby, sometimes I take them and go pick them back up. We help with transportation if that's where the need be. And then we follow them for 90 days, see them every week, 90 days postpartum. Make sure mom's doing everything that she needs to do as far as her physical recovery. We watch her mental health. It's a big piece of it. And then we watch the baby to make sure we're picking up weight, making sure the head comes into the right alignment, those little legs become unbowed, and all those things that we need to watch for the baby. We become very interwoven into the fabric of these people's lives. It is absolutely nothing for me to get 4 texts or phone calls a night. One thing that you guys were talking about too is this stuff doesn't happen between 8 and 4:30 every day. No nights, no weekends, no holidays. It's just not how it works. For whatever reason, babies decide to give mamas hard times at 3 o'clock in the morning. So we answer this phone because, like I'm sure everywhere else, if you have a problem, question, or concern, you call your on-call doctor, you talk to a nurse or a machine, and hopefully somebody calls you back. Meanwhile, if you're just what I would call a regular mom that's had no trouble, you're fretting, you're anxious. If you're a high-risk mom, we ratchet that up about 500 times. So a lot of times they will call me, and I will say, call the on-call, then we'll just kind of talk our way through it. Our educational points, again, we deliver everything on that we can really bring to you. Safe sleep, safe footing. I had to explain that to one of my doctors. They're like, what is safe footing? Well, that's making sure you're safe when you're walking, because when you're pregnant, your pelvis opens up, you get the duck waddle that we all get to laugh about, but also you can't see your feet. So it kind of makes you weeble wobble. You're going to fall. So we talked to them about slip fall hazards. We talked to them about going through their house, things like that. One of the other places that I feel like and just from anecdotal stories from the parents is I speak dad. Because typically what happens, you go to an OB appointment with your partner, and it's like, how you doing? Have a seat right over there. And the conversation is solely with the pregnant mom. Then you go to the hospital and have a seat right over there. We'll let you know when we need you. No training, no education. Comes time to cut the cord. Okay, come over here. You're not going to hurt them. Go ahead and cut it. Then in the hospital, you have that little red, the mom has that little red button. And that nice person comes whenever she pushes that little red button and asks for help. When she goes home, who becomes that little red button? Dear old partner. And if partner doesn't have the tools in his toolbox to help, what happens? He or she gets frustrated. So now you have a scared mom or an anxious mom, a scared or anxious dad, and what is the baby? We have just created the toilet bowl effect. That baby we think, that the baby is feeling emotions that they are mad. My parents, these people that are tasked with saving me or keeping me alive are now mad at me. They don't understand that it's not that. They're just short sleep. They're just short resources. Grandma, they don't want to bother grandma to come over and help. So we speak dad. So throughout the pregnancy, we work a lot with the partners as well, giving them those toolboxes in their minds to help facilitate and help with things like breastfeeding. By the way, I don't think I've mentioned it, but I always mention it. Females are amazing creatures. The things that your bodies can do, I'm a guy. I always understood that kind of special, kind of like you. But as I learned this stuff, I'm like, as a practitioner, that is just cool. The things that your body can do is just so cool. But there are times where you need help, and we need to have that partner that's available and ready to help you and knows what to do. So I think that's kind of it. We do work a lot with our social workers in our office as well. Unfortunately, Indiana is not immune to the opiate crisis and the SUD crisis. So we will get referrals from probation, we'll get referrals from DCS, we will get referrals from ER. People in the community had a mom come into the office, just kind of knocked on the door and came in. She didn't need to knock, but she did, and said, I need help for my daughter. She's pregnant and she's in heavy use. Okay, come in, sit down, let's talk. And then we were able to go out and engage with that person. I engaged on the medical side, brought our social worker in to engage on the mental health and SUD side. And as a team, we were able to navigate her and her beautiful baby boy. She's now clean 2 years, has an amazing job at Home Depot. She's like the front end manager. I don't know what that means, but so we utilize other parts of our MIH to assist us.
So this program, one thing with all of our programs, so I'm just going to touch on those. So we do chronic disease management. We've expanded that congestive heart failure to do all chronic illnesses. We have the maternal infant health side. We have a quick response team that goes on those 911 emergent calls and then does follow-up through social work. And then medics able to do Suboxone in the field as a gap until we can get them into proper treatment. We do immunizations. And then the need for the maternal infant health was large because we only had one medic focusing on that field. He's been doing this since 2017 and has seen over 200 moms and babies. So it's just constantly
200 moms.
Yeah. So once they graduate the program, we have more coming in. So there was definitely a need. We partnered with Franciscan Health at the time. So he is tied to working with those patients, but we do have other area hospitals within that 50-mile radius that we want to work with them as well, because not everybody in our community is utilizing Franciscan Health. So we've grown. We've added nurses to our program. We have 2, so we have 3 practitioners with that program, and again, a social worker. So kind of to the shortage of paramedics, it's hard to find the medics or the appropriate medics because there's a shortage on the fire and EMS side. So we are diversifying our practitioners the best that we can. The scope of practice does look a little bit different when we're utilizing a nurse versus a medic, but it works pretty well together. We have also looked at expanding our program from 90 days to a year. We're piloting that right now for our maternal infant health, making sure that those babies are hitting their milestones, immunizations are happening. Again, that's something that we can do in-house. So again, it's really just bridging those gaps and making sure that they're getting that continuum of care. We actually just got another grant to expand that to possibly 3 years because we realized that, and that was a need in our community. A lot of the first steps or head starts don't start until age 3, so we wanted to be able to help those individuals and not lose them in that time period. But one thing I really want to hit on with all these programs is the term that we use all the time is the shared value. So how we started this, we were fortunate to have the hospital buy-in, but that's not always easy, especially with a city-funded fire department. So a lot of hospitals think, great idea, but we can just do this ourselves. So there's the private side to it. So we really, really focus on what is in it for you, what is in it for me, and what is in it for our community? Who does it benefit? So we've learned to share that value. And I'm very fortunate that our hospital system sees that. So one of the things that we've been able to do is be fully integrated into their emergency medical record. So that's where that physician extension is super helpful. They go on a visit, they come back, they chart right in that person's medical chart. And then the doctor, whoever's on that care team, can then see it. If they are in the ER, if we have a 911 call, we're able to get into that medical chart and see what's going on. So that really helps bridge a gap, and I think that's what makes our program stand out just a little bit from other programs.
I tell you, one of the things I've taken from this discussion these 2 days is, number one, something that I'm very proud to say our mayor did is he stopped looking at what we didn't have and started looking at what we did have. And then the second thing is, I look at my friends from Maine here. We're just rural people. We help one another. You talk about your ambulance service that runs 80 to 120 runs a year. I guarantee you that it's probably been the same people on that for a good bit of time. And I would imagine that if one of them had an emergency, they had a neighbor that was going to come and help them. We did the same thing. One of the things that I think really helped our program grow initially was I'm the guy in town that I can pick up the phone and they're going to pick up the phone on the other end and talk to me. I don't have to send email after email after email or a letter or whatever. Because I've done a couple things, I'm kind of one of those guys in town that, Darren, oh yeah, I played a lot of softball.
He's also the coroner, so.
I am also the coroner, so.
But I feel like it's pretty typical in rural community. You wear multiple hats.
Yeah, lots of hats.
Yes.
But, utilizing what you have available, and we just help one another. We have a county that's just west of us that when they went from EMT ambulance to paramedicine, they called over and said, hey, do you have some of those senior medic guys, those seasoned guys that would come help us do it? I was one of those asked to go over. And one of the things that struck me that you were talking about was many nights I would be on duty and I would hear people would do the same thing. They didn't call the ambulance. They would bring them to the med shed. And then you'd open the door and Lord knows what you're going to get. So, I think Maine, Indiana, I would imagine all the states that we're all from, I think this symposium really highlights who we are and what we do.
So one of the things that we're now trying to do moving forward is replicating the program. So we have 92 counties in Indiana, and about half are just now starting to get interested in community paramedicine. It is growing, but we have no reimbursement for paramedicine. We don't have a standard. So that's one fun things about being innovative and small is we get to set that standard as of right now. So
and we are setting the bar.
And we are. So we're writing down everything kind of going backwards. I would have liked to have done this before we implemented, but as we go, we are documenting how we're doing it. We've created a manual on how to start a maternal infant health program, which I'm always happy to share with any community. We consult quite a bit and it's free, so that's even better, on what worked well and hasn't worked well.
And how to choose the right practitioner.
Yes. So the one thing I also want to share the partnerships are huge. So having that public health partnership, having the hospital partnership, your city mayor backing you up, again, I think is what has been successful for us. We've also partnered with local universities in the area. It's challenging sometimes to have to sit there and educate an intern, but it's amazing the things that they can produce for you, such as these manuals and data collection and all these research pieces that you need to show the success of your program. We're actually doing that right now. We're working with a research professor from Purdue University and utilizing her intern to do retrospective data collection for us. So we're looking at these other home visiting service programs like Nurse Family Partnership or Healthy Families, looking at their benchmarks. So preventing NICU stays, breastfeeding versus bottle feeding, vaginal versus C-section birth. And in the last few years, we've either hit that same benchmark as them or a little bit better. And I think that says a lot when we're working with medically high-risk women versus just, the wide population that these other programs serve. So we're very happy with the outcomes that we're producing. However, we want to be able to replicate it. So hoping that comes soon. Our mayor and EMS Paul Miller are our advocates at the policy and state level, which is a part of this as well. So yeah, we'll open it up for questions at this time if you guys have any. If you want to join us again, if you have any questions. Yeah.
This may be for all of you. I just wondered, when you're talking about expanding the scope of practice, if there's been any tension with the medical associations, like the doctors' associations in your states.
So Indiana is different than Maine. I don't know if many people know it, but every state has their own thing when it comes to EMS. Oddly enough, EMS was and still is controlled by the Department of Transportation. Yeah. At any rate, Indiana has always been one of the forerunners on scope of practice because we are so rural. So I have what's called an unlimited scope of practice in Indiana. However, that's been one of the sticking points with finding that particular nurse to come in because they have all those rules and regulations. They can't cross lines, things like that. So not only do we have to find a nurse that has a passion for this because they make what a paramedic makes, not what a nurse makes, if you get my drift, but they cannot do the things that I do. So what we do as a partnership is those patients that the nurses are seeing, if they have one of those situations where they need that additional scope, then I will step in and go take care of that bit of the business and then hand them right back to the nurse.
And I would say in Maine, it's a very different situation. The scope of practice for EMS providers is very limited. It's incredibly restrictive. We have a single set of statewide protocols. The Medical Direction and Practice Board, the group of authorizing physicians, wants to keep it very tightly limited. The Maine Delegated Practice Act is one of the most liberal in the country. It says that a physician or PA or independent nurse practitioner may delegate to any individual any part of their practice that is usual and custom to be delegated. And then in the last year, we added a little bit that says and you have to be sure that they actually know how to do it, and you actually have to know how to do it before you delegate. But other than that, what that's led to is us running into issues where the Board of Medicine would have absolutely no problem with what we're doing, and Maine EMS saying, well, we need to know exactly where the end of the EMS license ends, because if you're on our side, you can't do any of this, and if you're on the other side, we still think you probably shouldn't do any of it, but we're worried that the AAG for the Board of Medicine will tell us we have to go away, so we're not going to fight it too much. So it's been a bit of a dance. Ultimately, we decided we want to end up in under EMS so that this becomes a career pathway for EMS professionals that doesn't require them to find the right hospital or the right physician to delegate to them, because that's where we could end up, is that all of this and what you're doing is absolutely amazing, and I definitely need your card, because I can tell you where you can expand. You can expand into Maine. You've got some opportunities there, but that this could become Dr. Busko's band of paramedics doing all of this stuff, but no one else could do it anywhere in the state.
You had mentioned a little bit about home care, and I took that to mean on like kind of an emergency basis for folks. But thinking about the shortage in home health care workers for managing chronic conditions and people who need maybe more regular, like daily or a few times a week care, do you think there's opportunity to expand this sort of model into meeting those needs?
I mean, right here, what they're doing is exactly that. And that's what the community paramedicine that we're doing should do. And this actually also falls under the issue about scope of practice. Maine, in the last 2 years, changed its Nursing Practices Act. It used to be that a nurse in Maine could only delegate to an LPN, an RN trainee, or a CNA, a certified licensed CNA, and could not delegate nursing practice to anyone else. Well, that changed to basically mirror the Medical Practices Delegation Act, and they added a telemedicine piece, supervisory piece as well. So, in my mind, what that translates to is all of the nursing tasks that need to be done as part of home health or chronic severe disease management could be done via telenursing with our group, the Community Care Physician Extender, extending that in. We actually did a demonstration project with some CNAs and some of our wound care nurses on having the wound care nurse supervise CNA complex wound management in patients' homes, and we could certainly do that with this same group. The question will be, will Maine EMS let us do it? And this is where our community paramedicine laws were very loose. Maine authorized community paramedicine in 2009 with 12 demonstration projects. So we had 12 community paramedicine programs that looked nothing alike. You could not have found anything in between them except that they couldn't go to the patient's house using red lights and siren. Otherwise, it was 12 different things. And we are finally at the point 14 years later where the Community Paramedicine Subcommittee has just gotten to our board, our Medical Direction and Practice Board and the Maine EMS Board, a set of rules, a scope of practice that they're just now approving, which is sufficiently vaguely worded so as to allow us to do an awful lot, which again, there's an expansion opportunity. Yeah. Definitely need your card.
Yeah, quickly, I'll just add to that. We're actually piloting our chronic disease program for those that are managing but want to age in place. So you're going to hear that term, aging in place, coming up. So we're working with one of our insurance companies to look at what that's going to look like utilizing direct service workers. So what can that insurance company provide as a service to help with those in-home care, whether if it's grocery pickup, that's not so much the medical paramedic role. Yeah, but I think that's what's nice using the different practitioners. We're trying to figure out, okay, what's the social worker's role, what's the paramedic's role, and what's the nurse's role, and who else can we bring in through community health worker or direct service workers. It'll be interesting to see.
Just real quick, to your point of, is this going to be here for a while? If we think for 1 second that they've stopped retracting services, these healthcare systems, no, it's quite the opposite. They're going to continue. They're going to continue. They're going to continue. I would like to take his telehealth with me so that when I go see a mom, maybe I save her, because there's times where I still have to send them 45 minutes to the labor and delivery unit to be checked. If I could have that capability, I could save that family who has money for 1 tank of gas for this week. Maybe mom's needs to go to the hospital, dad's at work. That leaves me doing the transport, which I'm fine with, but I can't always do it. So this is not only going to be here, it's going to continue. And these two programs are the trailblazers. And I want to thank you guys for asking us to come here and for coming and listening to us.
Yeah.
Awesome. Thank you. Very, very inspirational. Thank you. So remember, there's cards in the back. And if you want to fill them in at your leisure, leave them in the basket or pin them up at the Colonial and think about how did the session change your thinking or drive you to action. Take the cards and help us out. Thank you.